Hello, this is Dr. Vijay. Welcome to video series on renal function test. This is part 3 where I will be discussing about serum urea, blood urea nitrogen, serum creatinine and various clearance tests. Of course, these clearance tests are used to estimate GFR. Again, in the GFR, we are going to study estimated GFR and different formulas to estimate GFR. If you haven't watched part 1 and part 2, please watch those videos and come back to this video. In the previous videos, I have explained different classifications of renal function test, and also in the part 2, I have explained urine analysis. First and foremost, we are going to study about serum urea or blood urea nitrogen. We all know that urea is end product of protein catabolism or protein breakdown. Proteins are made up of amino acids and amino acids consisting of amino group. So while catabolism of these amino acids, the amino groups are converted to toxic ammonia, and this toxic ammonia in the liver converted to waste material urea. Urea is nitrogenous substances, or also we can call it as non-protein nitrogenous substances, which is waste material produced in our liver and excreted in the urine. Normal serum or plasma urea level is about 20 to 40 milligram per deciliter, and there is a term called blood urea nitrogen. So blood urea nitrogen we can estimate directly or we can calculate by estimating serum urea. The normal blood urea nitrogen is about 6 to 20 milligram per deciliter. We can calculate by multiplying this factor to millimoles per liter. If you multiply 0.466 to blood urea, so we will get blood urea nitrogen. So this factor is derived by molecular weight of urea is 60 and molecular weight of nitrogen is about 40. So there are two nitrogens, so 60 divided by 28 will get this factor. When there is increased serum urea, we call it as uremia. There are different conditions where there will be elevated blood urea or serum urea. The reason for elevation of blood urea could be pre-renal causes like high protein diet, because we know urea is end product of protein breakdown, or certain conditions where there will be increased protein catabolism like any trauma or surgery, or even in diabetes mellitus or prolonged starvation. Dehydration, like in case of severe vomiting, diarrhea and burn, there will be increased blood urea. Even congestive heart failure, there will be increased blood urea. And GI bleeding, the gastrointestinal bleeding, where amino acids are absorbed and it will give more blood urea. Coming to the renal causes for uremia, any condition which affect renal function will lead to uremia, or in other words, any condition if the GFR is decreased, definitely there will be elevated blood urea, like acute glomerular nephritis, acute kidney injury and chronic kidney diseases. Another reason for elevated blood urea is post-renal causes, like obstructions might be due to stones or enlarged prostate, where we can see increased blood urea. There are few conditions where we could observe less blood urea or serum urea, like malnutrition, liver disease because urea is exclusively synthesized within the liver, and syndrome of inappropriate ADH secretion or SIADH, sickle cell anemia. Let's move on to serum or plasma creatinine. Creatinine is synthesized from creatine, which is produced in the liver with the help of 3 amino acids, glycine, arginine and methionine. So this creatine transported to muscles. The predominant amount of creatine which is synthesized in the liver transported to muscles, and in the muscle it is stored as creatine phosphate, where it will be utilized for the muscle contraction or ATP regeneration. Okay, the creatine converted to creatine phosphate, which is an enzymatic conversion with the help of creatine phosphokinase or creatine kinase. Now this creatine phosphate, which is present in the muscle, converted to creatinine non-enzymatically. So this creatinine is nothing but an anhydride of creatine phosphate or creatine, which will be present in our circulation and excreted in the kidney. This is one of the important renal function tests we are estimating in the blood. So normal serum or plasma creatinine level, it will be slightly more in the male, about 0.7 to 1.4 milligram per deciliter, and in the female it is 0.6 to 1.2 milligram per deciliter. Since we know creatinine is product of muscle metabolism, so it depends upon the body weight or muscle mass. And please remember, this value could be different in different laboratories because it depends upon the method they are adopted to estimate serum creatinine. Suppose they are estimating with the Zappis principle or chemical method or kinetic method, this upper limit could be slightly less, say about 1.3 or 1.2. Suppose laboratory adopting enzymatic method, it could be up to 1.4 upper limit. This level depends upon the body weight, muscle mass, age and sex. So far we have studied blood urea nitrogen and serum creatinine. With these values, especially serum creatinine, we are going to estimate what is called clearance test or renal clearance test. Renal clearance tests are done mainly to estimate GFR. So what is clearance test? Clearance test of any substance means the volume of plasma, which is usually in ml, from which a particular substance in the sense it could be urea, creatinine, inulin or cystatin C, completely cleared by the kidney per unit time, in the sense per minute. So clearance test usually expressed in terms of ml or milliliter per minute. Okay, volume of plasma from which a particular substance completely cleared by the kidney per minute is clearance test. The formula to calculate clearance test is U multiplied by V divided by P, where U stands for urinary concentration of this substance. For example, if you are doing clearance test with creatinine, then urinary concentration of the creatinine, and P means plasma concentration of that particular substance. For example, it could be creatinine, and here multiplied by V. V means volume flow rate of the urine, ml per minute. There are various clearance tests like urea clearance test, creatinine clearance test, cystatin C clearance test, inulin clearance test. The conditions satisfy clearance test where we can use different substances or markers, and these markers should freely filtered by the glomerulus and neither reabsorbed by the tubular cells nor secreted by the tubular cells. If these three conditions satisfy, and it will be a good marker. And apart from that, it should be endogenously synthesized. That means it should be derived within the body as a result of metabolism. First and foremost, we will see urea clearance test. Okay, it is synthesized endogenously within the liver, and this urea also freely filtered by the glomerulus. But the problem with the urea is, whatever urea is filtered by the glomerulus, among this 40 to 60% reabsorbed back to the tubular capillaries through the tubular cells. And another condition it satisfies is tubular cells will never secrete urea. So this urea clearance test is not satisfying all the conditions as a good marker for clearance test, because most of them are reabsorbed in the tubular lumen to the tubular cells, then on to the capillaries. Coming to creatinine clearance test, of course it is endogenously synthesized, which is a product of muscle metabolism, and of course it is freely filtered by the glomerulus and not reabsorbed. These three conditions are satisfied, but creatinine, a small amount of creatinine secreted by the tubular cells, which will give definitely more GFR than the normal GFR. And one more thing you need to remember, the amount of secretion of creatinine by the tubular cells will going to increase when there is more and more GFR decrease. That is, again, this is one of the drawback. Okay. Another substance or marker called cystatin C, which is a low molecular weight substance produced by all nucleated cells or endogenously produced and freely filtered. But here 99% or almost all cystatin C, which is filtered by the glomerulus, reabsorbed back to the tubular cells, and within the tubular cells this cystatin C is catabolized and they are not secreted by the tubular cells. So this satisfies almost all the functions, because here most of them is reabsorbed and degraded within the tubular cells. So this is a good marker again, but there are not a standardized or popular method to estimate cystatin C. Of course there is a definite methods for cystatin C, but these methods are not popular. Last substance is inulin, which is not produced in our body. We have to inject this substance to the patient, then it will go to circulation and freely filtered by the glomerulus. It is neither reabsorbed nor secreted by the tubular cells. This is again a very good marker to estimate clearance test. Having said that, we have to inject this substance to the patient. So if you look at urea, creatinine, cystatin C and inulin, so inulin would be the best substance to estimate clearance test. Having said that, we always use creatinine. So almost all clinicians use creatinine clearance to estimate GFR. The methods for cystatin C and inulin are not popular or not standardized when compared to creatinine. The ultimate goal to measure creatinine clearance is to estimate GFR. The normal GFR is about 90 to 120 ml per minute. So here afterwards, when I say clearance, it is creatinine clearance test. By using creatinine clearance test, we are going to estimate GFR. There is a calculation or term called estimated GFR, or we write eGFR. There are two popular formulas to estimate GFR. One is called Cockcroft-Gault formula or equation, and another one is called MDRD formula or equation. So MDRD stands for modification of diet for renal disease equation. So these two equations, there is no need to estimate urinary concentration of the creatinine, and all the parameters like age, sex, weight, muscle mass, body surface area are considered, so that it will be easy to calculate GFR. The two formulas are, one is Cockcroft-Gault equation. Here we have taken into account age, body weight and serum creatinine. Okay, there is no urinary creatinine estimation here. So this formula is for male. If you multiply by 0.85, this formula we can apply for female, because always creatinine depends upon the muscle mass and body weight. Next formula is MDRD equation. Again, body surface area, serum creatinine, age, and if female, we are going to multiply with this particular factor. So no need to memorize these formula. We are having so many apps in Play Store and App Store where we can enter these age, weight and serum creatinine concentration, height to calculate body surface area. It would give the exact estimated GFR. Not only in the App Store or Play Store, even there are several web-based calculator to estimate GFR, which most of the clinicians are using nowadays. So once we calculated estimated GFR, it would help to stage the chronic kidney disorders or grading the chronic kidney disorders according to the GFR. If the GFR is more than 90 ml per minute per 1.73 square meter of the body surface area, the GFR would be normal, but there may be minimal damage to the kidney. Okay, again this grading only for chronic kidney diseases. So the first grade or first stage means GFR is normal, but maybe there is mild damage to the kidney. Grade 2 or stage 2, where if the GFR is between 60 to 89, there will be mild damage to the kidney and slightly lower GFR. Stage 3 divided into 3A and 3B. In the 3A, the GFR between 45 to 59 and mild to moderate damage to the kidney with low GFR. 3B, the GFR range would be 30 to 44, moderate damage to the kidney and low GFR. Grade 4 or stage 4, the GFR would be between 15 to 29. Definitely there is severely low GFR and kidney damage. The stage 5 or grade 5 of chronic kidney disease, where GFR or estimated GFR is less than 15, definitely it is end stage kidney failure or kidney disease, and these patients require dialysis. Okay, these are few blood tests which we can use to assess the functions of the kidney. So far we have studied classifications of various renal function tests in the part 1 video. In the part 2 video we have discussed various urine analysis parameters, and this is part 3 where I have explained the different blood tests to assess renal function.